Good evening to one and all present here. So after a successful day one of the International Interventional Pulmonology virtual meet, in which we had witnessed the talks by expert faculties on various domains on EBUS. Now I welcome you all for the second day talk on linear EBUS and update. So today we have with us eminent faculties, Professor Kyle Hogarth, Dr. Angelina Tecano, Dr. Ajay Wog, and Mr. Royal to give us the insights into various aspects of EBUS which were not dealt in the previous day session. This will then followed by a panel discussion by eminent national faculties addressing to the real world challenges while doing EBUS. So again, I welcome you all for this event, and hopefully we will have a very good take-home messages at the end of the session. Thank you.
On day two, the first talk is a very interesting one. It's EBUS, scopes and needles. So to talk about this interesting topic, we have Dr. Kyle Hogarth, and who is a professor of medicine at University of Chicago. He is the director for bronchoscopy program, and he is the founder and first president of the Society for Advanced Bronchoscopy. Dr. Kyle Hogarth brings his extensive experience to this program. He has extensive experience in EBUS, navigation with robotic bronchoscopy, bronchial thermoplasty, and bronchoscopic lung volume reduction. Friends, please welcome Dr. Kyle Hogarth.
Thank you for that kind introduction. It's my pleasure to be here today. I wish, obviously, I was physically there. I've had the pleasure to be in India twice now and can't wait to get back someday. Obviously, until we can start traveling, here's me virtually. So the topic of needle selection and what to do with the needle in EBUS, I think, comes up frequently, and there's some literature to guide us. So I'd like to go through that briefly here. This is my conflict of interest. None of it really directly pertains to what I'm going to talk about, but there it is. So I think always when it comes to EBUS, first question is, why are we even bothering with CT and PET? Aren't they, quote, good enough? And can I get enough tissue with EBUS? And that's always the real question, especially for molecular markers. And where am I sampling? How do I sample? I'm not going to obviously go through all of this component in the brief time that I have, but we do know that CT and PET are not good enough. They are quite useful, but their sensitivity and specificity across multiple trials and a large meta-analysis is lacking. And more importantly, a lot of lung cancers are diagnosed and staged using small biopsy specimens. This is multiple different ways, obviously, to sample, but with EBUS being right here in the middle, but gone are the days where large pieces were given. We already know that we want adequate tissue and specimens should be obtained so you can define the histologic type and to perform a molecular analysis. So it's very important to make sure we get enough material. You would like to stage at the same time, and it's one of the advantages of EBUS that for many patients who present with more advanced stage lung cancer, you can both diagnose and stage during the same procedure. And you would obviously want to always biopsy the pathologic site that would confer the highest possible stage, contralateral lymph nodes, etc. A reminder of our mediastinal anatomy as far as our both vasculature and other structures, but more importantly, the lymph node stations. And in this particular example, the N1 nodes in a right-sided lesion. Here's another way to view it. I prefer this image from Mergu and Colt that really defines out the regions for our lymph node stages. Just one other view of it. And I put these up here just so that people can have easy access to them. Reminder, too, that EBUS, and then obviously the complementary EUS, there is almost every single station that we can get to, and why they are both a superior procedure to mediastinoscopy, not just because of less invasiveness, but because of the tissue we can get, the locations we can get. Obviously, start first at your possible N3 nodes, work your way down to the N2 nodes, and then on to the actual N1 nodes. So how do you go about sampling? Because that's the core question I've been asked to address. One, you always want to make sure whatever needle you're using is moved from capsule to capsule within the node, covering the entire diameter of the node. And you definitely want to always make sure you're getting some subcapsular area. It's very common with early EBUS users that people will jab into the middle of the node and essentially just back and forth across the middle. But some early adenocarcinoma mets are only subcapsular, so it's not always that the entire lymph node is replaced. We definitely do a method that my colleague and partner highlighted in his article, but the FASTER acronym of frequency and amplitude, so no need for suction, the time as little as possible inside the node, edge, keeping the needle inside the node at all times, and changing the direction and sort of so-called fanning within the lymph node while you're passing back and forth. So let's get into needle selection. So currently in the US, there are these 3 needles brands or companies available, and they come in multiple sizes. And they come in 2 different types from the Boston Scientific, 2 different needle puncture sites or puncture styles, acquiring different levels of potential tissue. I think what you're going to see when you look at the literature, there's a lot of limitations to our medical literature on this. Here's my personal take on that. The so-called best needle, I would argue, is the one you currently own, the one that you can afford, the one that gives you the best yield with your pathologist. Certain sizes may work better for certain clinical scenarios, and everyone has their biases about what size needle. Tell you my personal bias, I prefer smaller. There's less blood involved, and my cytopathologists prefer less blood. And I think that's the key here. If you have a so-called bigger sample with a bigger needle, but it's also got a significant amount of blood, some cytopathologists will have a hard time calling a lymph node normal because they will see a lot of lymphocytes, and they will argue it is from the peripheral blood. The point here is to have a conversation with your pathologists about your needles. And if you're not sure and you have the ability to try across several different needles, give samples from different nodes on one patient and just casually have a discussion with your pathologist and review what they like best, which slide looks best for them. And that might be, for you, then the best route to go. Because in the end, it's our colleagues that are deciding the so-called quality of your sample. Bigger isn't always better, though sometimes it is. And importantly, when you ask a pathologist what a core is, cores are anything visible as solid in the jar. If you can pick it up with tweezers, it's a core. So there's this belief that unless you can see something like the size of a fingernail or something ridiculous, that it's not a core. A thin ribbon of tissue is still a core. A core is what you choose to call it. So there's some literature, EBUS of a 21 versus a 22. You'll notice ultimately that when we were dealing with smaller needles versus whether they're equal, and looking at the blood contamination, the evaluating factors across each needle, kind of smaller studies, the 21 gauge did seem to have a slightly higher level of blood contamination, and it was statistically significant. You'll notice that diagnostic accuracy seemed to be about the same. So a larger needle didn't automatically get you better histologic specimens. Another nice paper looking at the 21 versus the 22, whether or not yield was determined by size. Again, not seeing anything statistically significant here. And comparing again 21 versus 22, characterized or non-characterized. The point being, when you at least look at those 2 sizes, not a lot of easy difference to make an argument of one size versus another. And what about a 19 gauge? So this was a nice study that looked at the Flex 19 gauge needle versus a 22 gauge needle for EBUS. You'll notice right here, across the p-value on the quantitative specimen, the tissue core present on a cell block across the 2, similar. Tissue surface area, not statistically significant. When you again look at the subgroup for cancer specimen outcomes, some areas I got close in the sense that the 19 might have gotten the medial tumor surface area to be slightly higher. This was extremely quantitative and potentially a trend towards slightly more DNA. One could also make a counter argument that all you had to do was take 1 or 2 more passes with the 22 and you might have had equivalence. I think the key to this is, again, one needle versus the other, we didn't see more DNA, which in the end is the real thing that matters. And then when you looked again at so-called bloodiness of the TBNA, there was a higher amount of blood in the 19 gauge, and it was statistically significant. So that's it as far as some good studies. There are, of course, company-sponsored studies talking about which needle requires greater or less force to penetrate the tissue. more cutting power, etc. Differences in needle point tips that may acquire more tissue or not. So then the question is the use of EBUS with either aspiration or no, and stylet. So again, not just what needle you pick, then what you do with that needle. So the nice paper by Casal et al. Was with randomized trial of ultrasound needle biopsy with or without aspiration. The short answer here is it didn't make a difference. And what aspiration potentially did was increase the amount of blood. So I can tell you after this paper, our own group, we stopped essentially applying suction to our EBUS sampling, with some exceptions, obviously, if you're getting very scant sample. Another nice trial from Dr. Lin, using to evaluate the utility of suction, and then also whether the inner stylet of EBUS-TBNA was important. You'll notice what they did here. Those who underwent bronchoscopy, 3 needle passes using suction with a stylet in place at first, then suction with no stylet in place, and then stylet with no suction, so the stylet was ultimately removed during the procedure, and then evaluating. The primary outcomes, you'll notice no difference. The subgroup analysis, essentially, really no difference. And so what does that tell us? There's a strong argument that adding back the stylus each time, et cetera, is only lengthening your procedure and doesn't seem to have any event or impact on outcomes. And I think a really nice quantitative study that from Schulten et al. That the stylet does not improve diagnostic outcomes. You'll notice when they looked at sample adequacy in the diagnostic sample with or without the stylet, no difference. And more importantly, the percentage of benign slides with few, moderate, or abundant lymphocytes. In other words, the fear that the stylet, with the lack of a stylet, would lead to contamination with epithelial cells. And you really don't see a difference one way or the other in outcomes. And so the stylet is an unnecessary addition per these studies, and it's something to consider in regards to not having suction and not using the stylus. Are you able to potentially speed up your ultrasound EBUS procedures? Now, you'll notice that none of these say it's worse with the stylus. So if your personal beliefs or how you do EBUS say that I'm going to do it with the stylus, I would make the strong argument that you're not wrong either. But I think when you see equivalence across multiple studies, both in size as well as stylet and suction and so forth, it leads open to either one, we can all do it one particular way, but I can make the argument strongly, as I said at the very beginning, that the best needle is the one that you work with, that your pathologist like your sample, and you're comfortable using. There's also been evaluations of the number of passes within the node, as well as how many jabs you should be making, or sort of, how many actuations. Typically, you start to get a plateauing of effect by about the third aspiration. Yield plateaus after about 3 passes. This is from Dr. Lee a while ago. And the number of jabs, a nice paper out of India actually looking at using a 22 gauge needle with suction. And this was in sarcoid, so not cancer, but did you have to essentially jab back and forth 10 times or 20 times? You'll notice no difference. And so the additional time in the node didn't acquire you more tissue in this nice paper. I was told to make about 15 minutes. I think I came right there close, maybe a little short, but I hope not too long. This is a picture of my institution, and we're in the greater Chicago area. We're in the city, obviously, but right here on the University of Chicago campus. This is the main collegiate campus, and this is the medical campus. If you find yourself in the greater Chicago area, please email me. Let me know that you're coming, and we'd love to have you come say hi, and we'll show off our bronch suite. We're really proud of it, my 2 partners and I. And thank you so much for everyone's time, and I appreciate this opportunity.
Thanks, Dr. Kyle Hogarth, for an excellent talk on EBUS scopes and needles. So to introduce our next speaker, we have Dr. Murali Mohan, who is a consultant pulmonary medicine at Narayana Hridralaya, Bangalore. Sir, please introduce our next speaker.
So our next speaker is Dr. Angela Takano. She's a senior consultant in anatomical pathology in the Singapore General Hospital. She has her expertise in neoplastic pathology and cytopathology, but her main interest is in pulmonary pathology, which is very heartening to all of us. And she works in both the neoplastic and the non-neoplastic areas of pulmonary pathology, cooperating very closely with pulmonologists, thoracic surgeons, and oncologists, not only in the clinical services, but also in diagnosis, research, and teaching. It's very important that we get rapid on-site evaluation, which will tell us about the accuracy and the yield of a test that we are doing. And it's pointless to go through a whole EBUS, both for the doctor and the patient, if it is not going to be yielding. So Dr. Takano is going to talk to us about rapid on-site evaluation and sampling with EBUS. Dr. Takano, please.
Thank you very much for your kind introduction and your invitation to participate in this webinar, Yashoda Hospitals. So I will be talking today about processing the EBUS specimen and rapid on-site examination and update. Endobronchial ultrasound-guided EBUS biopsy of the mediastinal lymph nodes is a state-of-the-art, minimally invasive technique which provides real-time direct visualization and access to mediastinal lymph nodes. The purpose is for staging of lung cancer and other non-pulmonary malignancies and diagnosis of granulomatous diseases. It also allows sampling of any centrally located mass for diagnosis. In this diagram published in the Archives of Pathology and Laboratory Medicine recently in a review, we have all the stations that are readily accessible by EBUS-guided TBNA. So the material obtained for diagnosis and staging of lung cancer has to be enough to make a morphological diagnosis of lung cancer, either by cytomorphology or histomorphology. There has to be enough material to perform necessary molecular studies. For example, here we have a case of a small cell carcinoma on a thin prep. And you can see the cells are small, hyperchromatic with salt and pepper chromatin. So this is a diagnosis that is a cytologic diagnosis. Then you have the formalin fixed paraffin embedded material that can be used to do immunohistochemical studies, such as synaptophysin depicted here. But in cases that you get material such as this, where the morphology is that of non-small cell lung cancer, you need to do immunohistochemical studies and also molecular studies if it turns out to be adenocarcinoma or squamous cell carcinoma in a non-smoker, or if it remains as non-small cell, not otherwise specified. So I'll show you the minimum panel recommended for the diagnosis of non-small cell lung cancer, and it's TTF1 and P40. If you have a non-small cell lung carcinoma morphology, if it's TTF1 positive, you favor adenocarcinoma. If it's P40 positive, you favor squamous cell carcinoma. If it's positive for both markers, it's a possible adenosquamous carcinoma, even though these are very rare. And if it's negative for both, you just call it non-small cell carcinoma, not otherwise specified. But you have to know that for all of them, you'd also need material for PD-L1 staining. So you need to have abundant or relatively abundant material to do all these tests. You have molecular tests that are recommended, are needed, EGFR, ALK1, ROS1, and you have even more molecular tests if your patients can be allocated to trials. So this material is obtained with your needles, and the question comes, does the size of the needle matter? So there's been studies comparing the sizes of needles and diagnostic yield. And the truth is that this diagnostic yield of needles between 21 and 22, there's not much difference. And these are the sizes that are generally used by pulmonologists. However, there is a needle of a larger gauge, 19 gauge needle, which by the view of this formula, it would mean that it produces a larger volume of material, and that is true, but it does not necessarily increase the diagnostic yield, and it can cause a lot of bleeding. So there's been also studies comparing the diagnostic yield of needles 19 gauge versus the 22 and 21, and there's no significant difference. When it may become useful to have larger amount of tumor sample is when you need to do additional research studies, or you need to sample for example, flow cytometry in cases of lymphoma and such cases. And even in the future, when maybe the number of molecular tests needed are increased. Okay, so needle passes, needle insertion from the airway into the lymph node or site of lesion from entry to exit. That's a needle pass. It entails about 5 to 15 excursions of the needle, and a minimum of 3 lymph node passes are needed for lung cancer staging. Increasing the passes above 4 does not necessarily increase diagnostic yield. So when you prepare to do your EBUS procedure, you need to have a table adjacent to your bronchoscopic table where you're going to prepare the sample. So here you see the pulmonologist or the assistant expelling the material onto a glass slide to make an air-dried specimen that can be stained immediately with DIFQuick and do a rapid on-site examination. You also have a formaldehyde vial to push material inside. It can be expressed onto a paper first and then into the formalin vial. And if you have extra material that can be rinsed into a cytolite fixative, this can be prepared later as a cell block or thin prep slides. So these are the smears prepared during the procedure. And I have to say the shapes are not the best of these smears, but as you as practitioners, you know you are under pressure for the time because the specimen clots. So you try to prepare your slides as quick as possible so that you can have material that is visible in these rapid on-site examination slides. Because if it's too thick, actually we cannot make a diagnosis even of adequacy on those slides. So basically you end up with air-dried slides that should have an ovoid shape if the smear is prepared properly, an ovoid or elliptical. You should have some clot material or that is called core material as well that you put in formaldehyde. If you have additionals that you can produce a smear and fix it in alcohol for Papa Nicolau stain, that's also good. And if you have extra to rinse in cytolite for thin prep, that's even better. So you have your set for DIFQuick stain for rapid on-site examination, and you produce slides. And again, this is to emphasize that the shape of the smear, if it's well prepared, it should be ovoid or elliptical like this. And if the material starts to clot, it will become a little bit more like this, which means that you were not able to smear it properly. The material from the cytolite can go into a centrifuge and make a pellet, which with thrombin and fresh frozen plasma can produce a clot. And this clot can be also fixed in formalin, embedded in paraffin, and produced like a tissue. This is a formula to prepare a cell block if you need to institute it at your place. So I'm just not going to go in detail on that. So during a rapid on-site examination, what you do is traditionally, it's done by a senior cytotechnologist or pathologist after each lymph node is biopsied. And traditionally, the purpose was to determine the adequacy of the cellular material and to generate a preliminary diagnosis. But in the age of targeted therapy, it also serves to optimize triage of cellular material for molecular studies. So there's pros and cons of rapid on-site examination. The pros are that you need less passes if you already have diagnostic material, so you can stop the procedure altogether. You improve the adequacy rate, improve diagnostic yield, and improve sensitivity. This is all from the point of view of the cytotechnologists and pathologists, because some recent studies, I have to say, found no difference between the use of rows or no rows for adequacy and diagnostic yield, etc. I think the most important contribution that rows does is for triage. To tell the pulmonologist whether you need additional material for diagnostic or ancillary testing if the diagnosis is such as a non-small cell carcinoma not otherwise specified, or even other malignancy that would need additional studies, such as a melanoma, for example. The cons are that you need an experienced cytotechnologist or pathologist on site. It takes a lot of time, extends the time of the procedure. If your pathologist or cytologist tells you an equivocal diagnosis, you may terminate your procedure prematurely. Other things are that the pathologist especially is not compensated properly for the time spent doing this, and it needs optimal clinical pathological correlation. So there's been few studies comparing how to define the adequacy criteria of rapid on-site examination. But basically, what you need to do to define adequacy is to determine whether the lymph node was punctured, and that the pulmonologist knows. So this last study emphasizes that whether you puncture the lymph node at least 3 times per node. If the core is more than 2 centimeters in appearance, it also is adequate. And of course, from the histological or cytological point of view, if you see malignant cells, if you have anthracotic pigment, and you have enough lymphocytes, such as more than 40 per 10 high power field. So basically, during the rows of EBUS-guided biopsy specimen, we ask these questions. Do we have adequate material? Yes or no? So if we get things like this, like a dense yield of lymphocytes, we know we're in a lymphoid area. And this is even suspicious maybe for a lymphoma. The other question is, do we have lesional tissue? And here we see a granuloma. So yes, we have lesional tissue. We know maybe we need to submit some for TB or other microbiological cultures. Do we have a malignancy? Here we know we have a squamous cell carcinoma or a small cell carcinoma or a non-small cell carcinoma, in which case we still need to do additional IHC and molecular studies, or we could have a metastatic breast cancer, for example, or a metastatic melanoma. So let's show some examples of EBUS-TBNA with Rose. This is a 69-year-old Malay man with enlarged mediastinal lymph node who underwent a station 4R lymph node biopsy. And here we already have the particles, which are the clumpy areas of sample material that contain the diagnostic material. It can be lymphocytes or tumor cells or granulomas. And in this case, we can clearly see that these are tumor cells and adenocarcinoma. So we have adequate specimen, yes, we have an adenocarcinoma, it's lesional. And do we know if it's primary of the lung or not? Of course, that the cytotechnologist doesn't know, or the pathologist, but you need to have a conversation with your pulmonologist to know the whole history, the radiological findings, etc. So we bring this to our lab and we finish the studies with the core material, in this case, showing a solid, this is a solid type adenocarcinoma, but it did not stain for TTF1, it was negative. So we cannot confirm it's primary from the lung. CK7 was positive. So that's when we need to do the radiological, clinical radiological correlation, and there is a lesion definitely in the lung parenchyma. So in that case, we can favor this being of lung origin and send the core material for all the molecular analysis needed, which at our institution is the so-called somatic solid tumor panel that includes a series of genes that include EGFR, KRAS, BRAF, and fish studies that are called quadruple fish because we do 4 fishes in 2 slides, ALK, ROS, RED, and MET. In this way, the cytogenetics laboratory was able to cut the cost a little bit. So basically, the purpose of ROS is to triage the EBUS-guided obtained material. So if we have a granuloma, as depicted here, we could go ahead and send microbiological studies. If we have a carcinoma, we make sure our pulmonologist gives us enough material to produce a cell block or material that can be used for molecular analysis. If we have something that looks like lymphoma, we have to have enough material sent probably in RPMI and enough in a histological block that we can do the corresponding studies. Another case of Rose is a 58-year-old Chinese male with cough and an opacity on a right apical area by chest X-ray. He had a history of TB and an enlarged station 7 lymph node. So this is the material obtained. The shape is right. It's an elliptical shape. So the smear was done properly, but the material actually is a bit limited. However, when we go on higher power, we can see that definitely there's lymphocytes and there's anthracotic material. There's quite a lot of lymphocytes. So we are definitely in the lymph node and there's no lesional tissue, there's no granulomas, we don't see TB, and there's no malignancy. So is it adequate? Yes, because we got in the lymph node location. It's not lesional, it's not malignant, and it's possibly just a reactive lymph node. So we studied also the ThinPrep material that was sent together, and it shows exactly the same. We have lymphocytes here trapped in this mesh with a lot of anthracotic material, so no granulomas and no malignancy. And the confirmation is a biopsy also of the lesion of the apical fibrotic area, and it showed only chronic inflammation, no granulomatous inflammation or malignancy, so no active TB really in that we could see in the lung or the lymph node. However, because of the history, the patient was put on few months of treatment to complete and be finalize the treatment and the follow-up. So a recent study published this year at the BMC Pulmonary Medicine by a group from China studied the values of different specimen preparation methods for the diagnosis of lung cancer by EBUS-guided TBNA. So basically, the findings of the study are that all the individual specimen types that you could sample with, that you could submit your EBUS-guided TBNA specimen would be of high sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy for the diagnosis of lung cancer. Individually, they're very similar, except that if you compare histologic preparation with traditional smear and liquid-based cytology, your histologic preparation has a statistically significant difference of diagnostic accuracy. So I guess the bottom line conclusion would be, if you have a difficult sampling procedure where you could not go back and you just obtain this much material, what would be the best thing to do would be to submit it as a histologic sample. So put your clot material into formaldehyde to make a block and fix in formalin and embed in paraffin. Now, if the material maybe is not very clotty and maybe a bit liquid, it still can be made into a cell block. So if you still squirt it into a liquid fixative, it can be spun down and centrifuge and made into a cell block with the technique that I showed you before. So that would be your best bet. But this also found that if you combine the different methods, such as your histological preparation, your traditional slide, and liquid base, you will increase sensitivity, specificity, positive predictive value, negative predictive value, but the increase is not statistically significant. So I think that's all for now, and thank you very much, and please keep safe. Thank you.
Thank you, Dr. Angelina Tecano, for an excellent talk on ROSE, the old and the new. For the next talk, we have Mr. Royal Verhoeven to deliver a talk on EBUS elastography, the known and the unknown. He's a technical physician in the Department of the Pulmonary Diseases in University in Netherlands. He has worked as a PhD resident on the topic endobronchial lung cancer diagnostic and is currently working as a technical physician in the Department of the Pulmonary Diseases, Radboud University in the Netherlands. His clinical and research focus include interventional pulmonology, flexible endoscopy, lung cancer diagnosis and staging, EBUS-TBNA, ultra-strain elastography, ultrasound imaging, and so on. He has got to his credit multiple international publications on EBUS elastography. And sir, kindly deliver your talk on EBUS elastography, the known and the unknown. Thank you.
Thank you. Today I'll talk about EBUS elastography, the known and unknown, a title given to me, and I'll do my best to appreciate it by this talk. My name is Rolf Roef. I'm a technical physician, and yeah, I'll just start off with what the current practice is, and that is EBUS-TBNA and EUS-FNA, and that combination has shown to be the current golden standard of systematic mediastinal staging in lung cancer. It has repeatedly shown to have high sensitivity and negative predictive value, especially if you do it systematically. And the downside here is that even if this has shown negative, but the suspicion remains, subsequent surgical staging remains recommended. And during these procedures, during EBUS-TBNA and EUS-FNA, lymph node selection is routinely based on PET-CT imaging and B-mode ultrasound features. A lot of literature has been published on also using B-mode ultrasound features for deciding on aspiration alongside PET and CT imaging, but the data has been shown to be contradictory. One finds the heterogeneous B mode feature, or the B mode feature that the lymph node is heterogeneous to be of most predictive value. One finds the size, and so on and so forth, which led to the guidelines concluding that it should not be used at all times, but only after individual centers have evaluated their own clinical value using these features. Well, instead of using the conventional B mode features, today I'll talk about ultrasound strain elastography, and specifically in assessing the chance of malignancy, as we have been studying for the past couple of years. Ultrasound strain elastography is like that of classical palpation. What you are basically doing is monitoring how tissue deforms by a deformation source. So for example, in classical palpation, you would use your two hands to triangulate a lesion and find how stiff or how hard this lesion was relative to other parts of tissue. This is exactly the same what we're doing with ultrasound strain elastography. However, in ultrasound strain elastography, what we are doing is we're using ultrasound. So rather than with your triangulation in classical palpation, you're actually adding additional information. You can have more information at one point in time. But really, it's quite similar. We're measuring while we're having a deformation source, and depicted in this image is that the transducer is being used to exert a mechanical deformation. And we see that sort of a, let me check with the pointer, that we're selecting a region of interest where we want to compute our deformation, our relative deformation, and that we see in B mode that the lesion is barely visible, while in the overlay we see that the circular inclusion is really stiff, so having low deformation, and the remainder of the tissue around it is relatively more elastic, being green in color. What is important here to realize, and what needs to be memorized, is that it's axial imaging, meaning we're measuring along the ultrasound propagation direction, and we're measuring how the tissue is deformed in that direction. So if we exert a force in this direction, we should preferably also measure in that direction. Another important aspect is that it's a relative measurement. So it's a normalized measurement, meaning that if you select this region of interest for calculating the strain elastography values, you will have always in this part of the image, in this color overlay, one part where the elasticity or the strain is maximally low or having low deformation, and a part where the strain is relatively high, meaning there's a lot of deformation. So it will also always be normalized as a part of the the complete image. So here's another way of visualizing it, and just to make sure that it's very clear, you have a first part of the image, a secondary image which you acquire, you subtract how the tissue has shifted from one image to another, and then you compute that and relay that back to the user in a color-coded fashion. So rather than using the ultrasound transducer as source, we're using the bigger vasculature and the heart as a deformation source, because we've noticed that we cannot use the EBUS or EUS transducer for doing this. So rather than using this, we're trying to use the vessels distal to the lymph node, and the lymph node being in between the transducer and the vessel. And since it's a relative measurement, and we can also quantify the what we see in multiple ways, and there's multiple measurement methods. I'll come back to that in a moment, but it's really important to keep in mind. Performing elastography since it's a relative measurement, you'll really have to use a standardized protocol. First, you'll have to scan, are there any artifacts? Can we really depict the lymph node in the most optimal way? Can we position the scope such that it will not move inside the trachea or move outside the trachea while we're doing strain elastography, because that will affect your measurements? And are we putting our system, are we using our system in the same fashion every time? Meaning, because it's a relative measurement, it's really important that you have your measurement settings optimized and standardized so that they are similar in a first measurement and a second measurement, all until your last measurement. This is what we see. If we use strain elastography and if we follow this protocol, we see here from A to D 2 malignant lymph nodes being depicted with really low strain, and 2 benign lymph nodes having less low strain, so being more elastic. As I said before, there's a couple of ways of measuring the EBUS elastography outcome. We could do so qualitatively, just saying, okay, what is the major color component that I see inside this lymph node? Predominantly blue, meaning low strain, all until red, meaning a high strain. But we could also say, for example, that we're going for a pattern scoring. This is something that has also seen application in breast lesions, for example, and which we also decided to study further by modifying it slightly, saying that we have a score 1 to 5, being relatively highly elastic until low elasticity, and adding in a last number X, being there's a vessel or something inside a lymph node that is causing artifacts, and these should not be performed measurements on. Then we have a semi-quantitative method, which from a idealistic point of view would be better to use because it would be more objective rather than a subjective qualitative scoring, where we have a first strain ratio, which has been repeatedly reported in the literature. You're selecting, after you've selected your area where you want to compute your strain for, you select a first lymph node region of interest, so here, and a secondary reference of interest where you think the comparison between the two would result in a representative comparison of how the lymph node would compare against remainder of tissue. As you can already see here, this would really be quite subjective to the user. For example, if the region of interest for the reference tissue would not be here, but be here, your strain ratio would be completely different. So rather, we said from a technical point of view, and what I'll also show later, is that what we see is that the strain histogram would be a better use, where you're just selecting the lymph node region of interest and compute that against the remainder of all the values that you found. And since this is a relative value, the software as we've used it would eventually result in a value between 0 and 255, a number without dimension because it's a relative number. So again, and that's maybe a known and unknown, really it's a semi-quantitative value, as I've repeatedly said, and in that sense, it's really important to have a standardized software and a standardized measurement protocol, because as you can see here, the way the colors are represented in your image might be varied by how it's translated, but also by making, for example, this measurement or this computation window too small, you would get a completely different outcome, as Haver et al. Has also shown. With these background, the technical background and the boundary conditions taking into account, we assessed how strain elastography would perform in a single center study first, and from there we went for a multi-center study. Here is shown how our single center study was done. We included 150 lymph nodes, and eventually after exclusion, we had 120 lymph nodes, which we then divided into a training data set for using all these assessment means upon, and then testing this in a new data set. What we saw is that the strain histogram mean from a technical point of view would be the most objective, and it also was one of the best performers from a clinical point of view. So in the training data set, it already had a sensitivity of 92% and a negative predictive value of 94%, meaning it would identify malignancy with good accuracy. And in the test data set, it even outperformed, but that also gave us a suspicion that it was might be the data set that we had was just too easy for the algorithm, and further study was needed. What we, however, did conclude, if you looked at all the numbers, so combining the train and test data set, we saw that the sensitivity and the negative predictive value could be indicative that strain elastography would have a good predictive value. So that was reason for us to continue with a multi-center trial, where we included several centers, and I also like to thank these centers for their contribution, the valuable contributions. We used the standardized measurement protocol we had made before, and alongside strain elastography measurements, we also included PET-CT measurements and B-mode imaging information, just to be complete and to eventually be able to compute a clinical algorithm of how strain elastography would add to already clinically available information. We eventually included 327 study subjects with a total of 525 lymph nodes where measurements were made. And we found that alongside strain elastography, being seen here, the ultrasound short exercise had good predictive value, good objective predictive value, having an area under the curve of 0.78 overall. The strain had a quite similar value, being 0.77, and since PET accuracy in our case was a avid, intermediately avid to not avid, we could not compute a area under the curve, but only an accuracy, and we saw that it also had predictive value. So we computed this, and we then stated, let's see how it would perform in this multi-center trial, and we saw that the mean strain, if we took a cutoff of 115, would have good sensitivity and good negative predictive value, but it would have a lower specificity and positive predictive value, as what we saw in our pilot study here, as in our first explorative study. But because we also stated that it would be, we could not ignore what was already clinically available. We should have to further include ultrasound size information and PET-CT information to really see what the added value of strain elastography could be. If we look then at the ultrasound size, we see that historically the 10 millimeters has been used, but recent studies have been using 8 millimeters. And we see that 8 millimeters does not have the best accuracy, but it does have good sensitivity, negative predictive value. And if we then combine that, knowing that 8 millimeters would probably become the new standard, it showed that combining it with strain elastography, we reached sensitivities of up to 98% and negative predictive values of 91%. But again, lower specificity and positive predictive values, also a lot of false positives. But since we're combining now different numbers, rather than having one outcome, so one sensitivity and one negative predictive value, it would be more valid to represent a workflow. So here we've combined this. So from going from our disease prevalence, which is 1 in 2.8 lymph nodes, 2.08, a 0.48 disease prevalence. And we see that adding in EBUS information increases the chance of malignancy. Adding in strain information also increases the chance of malignancy with a lower strain, meaning a lower number, meaning a lower strain, so a stiffer node. And that went from left to right. It's a logical relation, meaning bigger lymph nodes, smaller lymph nodes having less chance of malignancy, and a strain being lower, having a higher chance of malignancy, and a high strain having a lower chance of malignancy. And this corresponds in this whole workflow. And if you would compute it into another fashion, you would see that the probability of malignancy goes along with the slide shown here. And if you then add in PET information, as we had for 370 lymph nodes of our total of 525 lymph nodes, we see that it also adds up correspondingly, going from FDG PET AVID, lymph nodes that are enlarged and being relatively stiff, having an almost 1 in 1.37 lymph nodes being malignant, to negative lymph nodes smaller than 8, high in strain, so meaning elastic, having a 1 in 16 chance of being malignant, which is also depicted here. So to discuss and to conclude, we find in a first explorative study and a secondary multi-center trial that strain elastography has good predictive value. It seems to combine with already clinically available information, and it can improve the risk stratification. We need to restate that the standardized assessment is essential. Different centers need to validate their own strain elastography measurement method before they are trying to use it to predict lymph node malignancy, because there's system variation as well as patient cohort variation. And we definitely see a possible role for manufacturers in there for standardization. And we think that based on our findings that also the cutoff criterion for aspiration from 10 millimeters, which has been stated previously, should be lowered to 8 millimeters by default, and that we recommend also adding in strain elastography to this algorithm. Last but not least, we haven't discussed it here. We would also say that it's worthwhile to assess if strain elastography could be useful in other diseases as well, for example, in sarcoidosis. But that is preliminary data, and we should assess this further. With that, I'd like to conclude and also close. And I'd like to acknowledge with that very much the international research team, which we have been collaborating with, but also our internal facilities in Nijmegen. Thank you.
Thanks, Mr. Royal, for a comprehensive talk on EBUS elastography, the known and unknown. And to introduce our next speaker, we have Dr. Satish, who is working as a consultant pulmonary medicine at Vikram and Fortis Hospital, Bangalore. Sir, please introduce our next speaker, Dr. Ajay Vaughan.
Thank you very much. I welcome all of you for this evening webinar on EBUS in COVID pandemic time. Dr. Ajay Vaughan, the next speaker, is an assistant professor of medicine pulmonology at University of Chicago, USA. He has specialized in interventional pulmonology at the University of Chicago. His clinical interests include advanced bronchoscopy, complex airway disease and pleural disease. He has published in the American Journal of Physiology, as well as co-authored a book chapter in Murray and Nadal textbook of respiratory medicine, which used to be the Bible of respiratory medicine. He is interested in developing and investigating minimally invasive devices and techniques used to treat patients with both benign and malignant lung disease. He will be delivering an important talk on EBUS in COVID-19 pandemic time. Dr. Ajay Wagh, the screen is all yours and over to you. Thank you.
Thank you very much for the introduction and inviting me today. My name is Ajay Wagh. I'm an assistant professor and a new junior faculty member at the University of Chicago in Interventional Pulmonology and Critical Care Medicine. And today I've been asked to discuss and speak about bronchoscopy and endobronchial ultrasound during the COVID-19 pandemic. I have no relevant financial relationships to disclose. So today I'd like to go over briefly during this brief talk, review basic EBUS concepts and mediastinal evaluation, and then discuss the approach to bronchoscopy during the COVID-19 era, which has been a major issue for us pulmonologists during this time. So starting out with endobronchial ultrasound, we'll review again basic EBUS concepts and convex probe and radial probe EBUS. So convex probe EBUS really allows us to evaluate central airway abnormalities that are adjacent to the central airways, hilar structures, parabronchial masses, and it allows us to get real-time evaluation and guidance of transbronchial needle aspirates of these areas. Here on the left picture, you see the areas in yellow are accessed by EBUS-TBNA as well as mediastinoscopy, but more importantly, you can see in pink the areas that are able to be accessed by EBUS-TBNA. The areas in blue are able to be accessed by EUS or endoscopic ultrasound, typically performed by a gastroenterologist. Usually, when we evaluate patients' mediastinum, especially for lung cancer, the contralateral lymph nodes are typically seen as N3 lymph nodes, followed by N2 in the mediastinum, and followed by N1 in the ipsilateral hilum and intralobar region. Here we see a picture demonstrating the endobronchial ultrasound tip on a bronchoscope. So here is the endobronchial ultrasound that is connected to the bronchoscope with a sheath that carries the needle, which we use for sampling. Adjacent to that is generally the image that we can see, the ultrasound image adjacent to the bronchus here on the left. Moving on to radial probe endobronchial ultrasound, typically called REBUS or radial probe RP EBUS. This is a probe that's generally used for the evaluation of peripheral pulmonary lesions. Here you can see a therapeutic bronchoscope that has a radial probe EBUS probe, and this probe has a tip that rotates, giving us here on the right side a circumferential view of this nodule here. So let's move on to EBUS for mediastinal staging of non-small cell lung cancer and modalities for staging. So this is a chart that was taken out of my partner's review article in Chest 2014, Dr. Tim Mergu. And what was interesting about this chart was how sensitive the EBUS and endoscopic ultrasound is for lung cancer, and compare that to video-assisted mediastinoscopy. Obviously, all three modalities have an even higher sensitivity, but it really demonstrates the power of the use of endobronchial ultrasound and endoscopic ultrasound. a minimally invasive technique for mediastinal staging. We think about PET scan a lot when we evaluate the mediastinum. However, the PET scan is really not as sensitive in evaluating mediastinal metastases, around 75 to 77%. And therefore, there are several false positives, and we see those in active infections and inflammation and conditions like sarcoid. You can see anthracosis frequently, infections. Typically, we can see reactive lymph nodes light up on PET scan, and even recent lymph node sampling. So it's important not to obtain lymph node biopsies and then follow that up with a early PET scan. We also see false negatives where there's impaired blood flow. Necrosis can cause problems for a radiotracer reaching the area. And also processes with low metabolic activity can demonstrate can have false negative scans, things like carcinoid and even some low-grade adenocarcinomas. Again, out of Dr. Murgu's chest review, we followed this algorithm for mediastinal staging here at the University of Chicago. If mediastinal lymph nodes are evaluated on CT or PET, if they are seen to be negative, if there is clinical N0 peripheral tumor and that tumor is less than 3 centimeters, you can consider proceeding on to surgery. If those lymph nodes are seen to be negative and we are concerned for clinical N1 central tumor, a larger tumor, or even one with low SUV max, which can be seen in some indolent tumors, also known to have, not unusually, N2 occult disease, we typically follow that up with a tissue confirmation with EBUS-TBNA. If those are negative, we can consider surgery at that time. Mediastinal lymph nodes that are positive on PET scan, of course, we will be considering those patients for tissue confirmation by EBUS. If those are positive, we would then follow that up with multimodality treatment. If, however, our EBUS is negative and there is a strong concern for disease, you may follow that up with video-assisted mediastinoscopy, and then if that is negative, potentially proceed on to surgery. So let's move on to bronchoscopy during COVID-19. This has really been an evolving process for all of us in this entire world and for all of humanity. So really, it is what we have found is that these procedures are dependent on the availability and management of PPE. We also have found that this has been initially difficult due to need for more testing and the availability for pre-procedural testing. And we have really made our decisions on performing these procedures based on medical necessity and time sensitivity. So that is the clear issue that we think about when we're thinking about patients doing high-risk procedures and for sure aerosol generating procedures. Additionally, there have been a lot of hospital policy changes that caused a little bit of difficulty early on in the pandemic for us. This is social distancing management, changes to our visitor policies, and also temperature check and sanitizing stations at the hospital entrances. So PPE for bronchoscopy during COVID-19 includes, first and foremost, hand washing, then masks, and in this case, N95 or PAPR masks, eyes and face shields, caps, gowns, gloves, shoe covers, and there also needs to be good teaching and education regarding donning and doffing of the PPE, because this is typically, or this can be done incorrectly without proper education. Initially, there were recommendations in April 2020 out by the ACCP regarding the management of lung nodules and lung cancer screening. And this was when we really just didn't know very much about the illness. And their recommendation at the time was to delay the initiation of lung cancer screening, surveillance of those patients who had lung RADs 1 to 2 on surveillance low-dose CTs, surveillance of low probability nodules, or even those with indolent cancer, you could delay those by even 3 to 6 months, and even treatment of clinical stage 1, although I would not recommend that for a prolonged period of time, even 4 to 6 weeks. They did recommend at the time proceeding with PET or non-surgical lung biopsy for patients who had lung RADs 4 or with a fairly high estimated probability of malignancy of 65 to 85%. And then also proceeding with radiation or surgery, if amenable, for patients who had high pretest probability lung nodules for lung cancer. And more recently, here are the summary recommendations from September 2020 in CHEST from Dr. Wahidi and colleagues. This is basically a summary of the summary. Use full PPE for bronchoscopy if COVID positive. And frankly, there's pretty high rate of community transmission across most areas of the world. In this case, consider wearing full PPE regardless. Test for COVID pre-bronchoscopy, and we perform this generally within 72 hours. It is okay to postpone non-urgent bronchoscopy. And in such cases, it's reasonable to wait a month and prior to any bronchoscopy, get 2 negative COVID tests about a day apart. And again, we want to focus on patients where their condition demonstrates medical necessity and time sensitivity. And such procedures should be done and should be followed with the PPE guidelines as I discussed earlier. If you do not have such ability to perform this based on resources, consider referring that patient to a different center. So regarding the timing of bronchoscopy in lung cancer, and especially in light of COVID, really the concern is the risk of upstaging non-small cell lung cancer. And this has been demonstrated to be seen even as early as 6 weeks afterwards. The radiation oncology guidelines suggest not delaying treatment with radiation for more than 4 to 6 weeks when initiating treatment for locally advanced disease and in patients who require palliative treatment. So in the most recent WABIP newsletter, my colleagues, Dr. Ho, who is our Interventional Pulmonary Fellow, along with Dr. Mergu, wrote in the guide in this publication to not really defer bronchoscopy for the following scenarios. And number one, that would include need for tissue diagnosis for solid nodules, especially those that are more than 2 centimeters in size when you're concerned for lung cancer. When there's a suspicion for N2 and N3 nodal positive lung cancer, also don't defer when you're working to confirm stage 2 disease for neoadjuvant chemotherapy, confirming stage 3 for definitive chemo and radiation treatment for inoperable patients, to confirm limited stage small cell lung cancer for chemo and radiation treatment, and to obtain a tissue diagnosis of lung nodules in order to obtain next generation sequencing and PD-L1 to initiate first-line therapy in advanced disease. And finally, to confirm symptomatic progression for patients who need second-line therapy. Other procedural considerations that we have encountered. Really, when we're performing bronchoscopy, we want to minimize the time of aerosol exposure. And that is why it is recommended that the most experienced operator performs the bronchoscopy. We want to minimize the personnel in the room. We at this institution have preferred intubation and general anesthesia over moderate sedation. And in such case, we have been able to create a closed circuit for respiratory secretions. Additionally, during the intubation, we limit the bagging during pre-oxygenation. We previously were using intubating boxes, but now we have been using full PPE, of course, along with the use of video laryngoscopy. We use a HEPA or viral filter on the ventilator circuit, and we also use paralytics to avoid coughing during the procedure. We also make it a point to minimize repeated introductions of the bronchoscope into the airway, and in such case, you can consider clamping the endotracheal tube during entry and exit of the bronchoscope. So the take-home points for today's discussion. We discussed radial probe EBUS used to diagnose peripheral lung lesions, using convex probe EBUS used to diagnose more central lung lesions that are adjacent to the central airways, along with the staging of lung cancer. And we also talked about proper precautions that must be in place to ensure safety for patients and medical staff during bronchoscopy. I'd like to thank our interventional pulmonary team at the University of Chicago, Dr. Kyle Hogarth, Dr. Tim Mergu, Dr. Elliot Ho, Miss Kimberly Sivertson, Kathy Connor, and Tanya Casey. They are an immense help and a great team to work with. I appreciate your attention today. Do you guys have any questions or concerns? Thank you very much.
After the talk on the EBUS elastography, now we move on to the panel discussion. So to moderate this session, we have an eminent speaker as well as a pulmonologist, Dr. Rajada, who is working as a consultant in Fortis in Calcutta. And in the panelist, we have Dr. Nagarjun Mathuru, a consultant at Yashoda Hospitals, Somajiguda, Dr. Hari Kishan, consultant interventional pulmonology at Yashoda Hospitals, Secunderabad, Dr. Vishwanatha Gellar, who is working as a consultant pulmonary medicine at AAG Hospitals, Hyderabad. And we have Dr. Nagarjun, Dr. Arjun Khanna, who is working as a consultant pulmonologist at Yashoda Hospitals, Delhi. And Dr. Ugender Bhattu, who is a consultant at Yashoda Hospital, Malakpet, Dr. Yugvir Gaud, who is again a consultant at Yashoda Hospital, Malakpet, and myself. So, Rajada sir, you can please take over the stage.
Thank you very much, Vishwesh. Absolute pleasure to be a part of the program and also to be leading the so-called Young Brigade. You can see on the screen that we've got guys in scrubs and with caps and gloves on. So they've just taken some time off from their busy COVID work and this panel discussion. So we'll try and make it short and crisp and interact with all of you. We'll take questions which I think the panel thinks are relevant to the audience who is listening in today. And hopefully this will be a session which is fruitful for all of you. So I'll start off with Nagarjuna, is back again. So Nagarjuna, we'll start off with questions which will seem random, but hopefully there'll be an order to it. There'll be a little bit of discussion. So I want to find out from you, what would you do if you have someone who is got enlarged mediastinal nodes, PET negative, has had an EBUS, which is also negative. And this is someone with an underlying lung malignancy. So what would your approach, how would you go about managing someone like that?
So the clinical scenario is that the nodes are enlarged on mediastinum. So the next important thing is, what is the size of the lymph node? Is it more than 1 centimeter or is it a subcentimetric node? So if we go per the guidelines, if it's a subcentimetric node, you've done an EBUS, EBUS is negative, then that is reasonable enough evidence for us to proceed if it's a surgically resectable malignancy. But if you have a surgically resectable tumor with enlarged lymph node, in the sense more than 1 centimeter, and an EBUS comes negative, then the question is it a false negative EBUS? So at that point of time, then I think we should discuss with the patient and then take a call, because you don't have any clear consensus as to how to go about whether to do more invasive surgical sampling or to go ahead for a surgical resection with an intra-op frozen section and then proceed. The problem in India, I think, is availability of a good surgeon who can do mediastinoscopy at all places. There are only a couple of centers where mediastinoscopy facility is available. So in our setup, if the nodes are reasonably enlarged, and then EBUS has been done at a center, at another center where you're not sure whether the technicality was adequate or not. So if you're strongly suspecting the mediastinum to be involved, the next thing would be to redo an EBUS And this time probably you would do it with a better needle. So now you have needles which are 19G, or you can try for a forceps biopsy, which people are also trying. So this is purely because of the logistics we have, that we do not have access to good surgical medistinoscopy facilities. So this is what I would say, if the nodes are enlarged. But if the node is less than 1 centimeter and the EBUS is negative, probably I would stick to the EBUS report and then proceed to the surgical resection.
So Nagarjuna, just to sort of push this question a little bit forward. So let's consider for a moment, we are talking about nodes which are more than a centimeter inside. We're not talking about sub-centimeter nodes. I completely agree with what you said about the sub-centimeter node. So more than a centimeter, you have done, your center has done the EBUS-TBNA. You've got a negative yield from the EBUS-TBNA. The patient has got surgically resectable lesion. If you keep aside the enlarged more than 1 centimeter node, if you had access, if you had cardiothoracic surgeons who were happy to do a mediastinoscopy, are you telling me that you would actually send the patient for a mediastinoscopy rather than a perioperative mediastinoscopy and proceed with surgical resection and a frozen section? Is that the carry home message for the audience?
So if we have a facility to do a surgical mediastinoscopy, then probably perioperative mediastinoscopy is good enough. So you do the mediastinoscopy when the patient is on the table for the surgical resection, do a frozen section, and if it is positive, you defer. If it is negative, you proceed for a surgical resection.
Sure. Okay. So I completely agree. Anyone on the panel who has anything to add to that, anything to change from compared to what Nagarjuna said? So I'm in complete agreement with him, but anyone on the panel who's got anything else to add? Okay. So we'll proceed and we'll come to Hari. So Hari, you've got a scenario similar to what Nagarjuna was describing just now. So someone with a confirmed malignancy again, sub-centimeter lymphadenopathy. So I'm not saying insignificant, but sub-centimeter nodes in someone with a confirmed malignancy. What would you do? Would you actually try and attempt an EBUS to stage the mediastinum? Or would you say we'll not waste valuable time? We'll go ahead and do a surgical intraoperative lymph node sampling and do a frozen section in these patients, Hari?
It all depends on what kind of malignancy it is. Like if you have a tumor on the right side and if you are seeing a small nodes on the left side, so the surgeon may not go and do, he'll be doing a right-sided thoracotomy, right? So I don't think a surgical intraoperative staging is the answer for such kind of situations. So a preoperative EBUS is definitely essential, even though because radiologically a subcentimetric node or a non-significant node is something that is less than 10 mm on the short axis. But in real world scenarios, when you go in with the EBUS, you see the nodes are more larger in size than the CT sizing. And also, if you compare data on the small nodes, just looking at size of the node doesn't always exclude malignancies. So it is one of the characters. So most of the times you biopsy using FNA using a EBUS with a small node, you turn up most of the cases you will end up hitting benign nodes, but still there are 20 to 30% chances where they end up being malignant. So I do prefer doing EBUS staging for all cases before giving it to the surgeon for a surgical decision, especially in a suspected surgically resectable tumors. It is always preferable to combine EBUS mediastinal staging with surgical CT staging as well.
Sure. So Hari, agreed. So what you're saying is that you would go ahead, and if it's obviously contralateral nodes, you would do an EBUS because the surgeon might not be happy to do a surgery and an intraoperative sampling. Like you said yourself, your chances of getting a positive result is not going to be very high here. It's got sort of somewhere in the middle. As you said, 20 to 30%, let's say 40%, but maybe not more than that. So suppose your sampling came back as being negative. So what sort of conversation would you have with the surgeon at that point of time? And what sort of conversation would you have with the family and the patient?
You look at the real scenario, like you have such a node, sometimes you will not be able to hit those nodes using your EBUS needle because very high up 4L, very small node, you don't have a 25 Gauss needle there. So you combine your sonographic features. If you have those features also showing it is not a malignant node, maybe you can add on to the value of the EBUS FNA of the other nodes. Okay, if it is a, like if you, example, you take a right-sided tumor and 11L and 10L will be easy, but a small 4L is always difficult to FNA those lesions. So I think we need to assess before surgical resection with an EBUS. If not able to do an FNA, try to characterize the nodal characteristics on the B mode imaging and then talk to the surgeon and then go ahead. That will be
sure. So you will tell the surgeon that based on the appearance on ultrasound, the fact that we have not really got a positive result on the FNA, if you feel that the ultrasound pictures are benign, we tell the surgeon that please go ahead and tell the family that the chances of this being a malignant node is low. And equally, if it looks malignant. So do you think, so I saw Vishwanath raising his hand. So I'll ask Vishwanath. I was also going to ask you the next question. Do you think that's really evidence-based? Do you think that, I know it's a difficult question to answer, but do you think the ultrasound, the sonology pictures of a node are definitive enough to call something as being benign or malignant in the background of someone having a mass in the lung? Vishwanath.
Yeah, I think most of us are aware of the study by Yasufuku et al., wherein they have characterized the lymph node characteristics, shape, size, the appearance, and all these things, and just predicted the possibility of it being a benign node or malignant lymph node. So here also, I think this is all about the probability. So if you have a node which is less than 1 centimeter and then no heterogeneous hypotexture, definitely the probability of it being a malignancy would be very low. And then one more thing which I wanted to add is that suppose if there is a peripheral lesion which is less than 3 centimeters in size and a PET negative mediastinum, I think I would be happy with one EBUS staging where the lymph node sampling is negative for malignancy, and then I would refer the patient to the surgery.
So remind me, so Hari or Vishwanath, the Yasufuku study looking at the sonology appearances of the node quoted a sensitivity about 70 to 73%. That's correct, isn't it? I mean, so that's about a 1 in 3 or a 1 in 4 false negative or a false positive result, isn't it? So that's the sort of percentage that we are looking at. So I take your point. I think it's a difficult situation. And I guess you will have to sort of, the surgeon and the patient will have to take a call as to how much of a risk they will take in relation to the benefit that they're likely to get from having a curative surgery. So let me come to you, Vishwanath, different tack altogether. So do you guys do rows in your unit? And if you do rows, do you do a pulmonologist looking at the slides as in a prose, or do you actually have the luxury of having a pathologist come in and sit with you and look at your slides when you are doing your EBUS-TBNAs?
We do rows during the EBUS actually. So we had the luxury of having a pathologist in the endoscopy room during the EBUS, but during the COVID times, they're afraid to come into the endoscopy room. So we are forced with the doing the rows. We are trying to train ourselves with rows these days, just trying to observe it. The cytotechnician is coming, but the pathologist is not coming.
Grand Vishwanath. So even COVID can have some beneficial effects, isn't it? So from rows, you're getting into pros. Wonderful. So can I have a show of hands? How many of you have rows in your units? Okay, so 1, 2, 3, 4, 5. Okay, all right, everyone. Okay, wonderful. So I will keep my hand down. So we don't have rows. We are trying to train our DNB postgraduate trainees to do pros rather than rows. We don't have the luxury of having it. And I mean, randomly, anyone could answer. Do you think it's made a big difference to your yield? Anyone, maybe Hari? Do you think having rows, there must have been a pre-rows era also? Do you think it's made a big difference to having rows, or do you think your results have remained more or less the same?
I'm just 2 years into practice, and the moment we came here, like we started doing rows, and in our institute we do rows by ourselves. Okay. So we are able. I don't have a comparative data without rows and with rows, but definitely it will help us to tell the patients on like after the procedure immediately what we are looking in the EBUS.
Sure. Anyone, any comment? Yes, Arjun.
Can I make a comment?
Yeah, Nagarjuna.
Yeah, see, because I have a combination. I used to do without rows when I was in PGI. And then once I started in Yashoda, from day one, I had luxury of having a rose. So what I would strongly say is that rose actually makes a lot of difference. Because one thing is, though most of the guidelines say 2 passes is sufficient, 3 passes is sufficient, sometimes it is not always true. So when we have a pathologist with us, we can spend more time. If we have a diagnosis, it's good. If you don't have a diagnosis, you can sample different nodes, different parts of the node till you get a diagnosis, number one. Second thing, how Rose also helps us is to triage the sample for ancillary investigations. Suppose you have a granuloma, which the pathologist says, you would take more sample for probably microbiology. And suppose if you have the rose saying it as a malignancy, you would want a cell block or a core biopsy or whatever it is.
Sure.
And further, the rose also helps us in another way. We also ask the pathologist when we have a tumor as to which node has more yield of the 3 different nodes. So they also tell us which node, which part of the node, which sample had better tumor content.
Sure.
And that part we will sample and we will use that for the cell block. So this also increases the yield of the molecular test. So Rose actually helps us in several ways. It actually increases the yield because if you don't get a positive on one node, you sample other nodes. It decreases the time which is required for sampling, and it also helps us choose the ancillary investigations more wisely and also collect the sample from the correct node for the molecular test. So I think whenever feasible, I think Rose has to be a part of the EBUS setup.
Sure. I'll come to you, Vishwanath. I saw Arjun's hand, so I'll come to Arjun with this question, your comment, and something to add in. I absolutely loved Nagarjuna's answer, but you know, the literature is actually divided. So you have studies where Rose does add something as far as yield is concerned, whereas equally there are studies where Rose doesn't seem to increase yield. Like take all the other points that Nagarjuna made, but yield doesn't seem to be very different. So that's one. And I want a comment from you. And second, I also wanted to ask you about doing Rose, doing maybe 3 passes and still having a negative result. So what would you do? What would your strategy be at that point of time? So Arjun.
As you know, we tend to climb the learning curve as we negotiate the learning curve. A lot of us do tend to move away from Rose. And you know, if it's a large node where I know it's TB versus sarcoid and those kind of cases, and the literature also suggests that you can do without a Rose in those situations. However, if it is a staging procedure, it is a difficult patient, subcentimetric nodes, the kind of patient that we were discussing, you know, wherein the Rose, the diagnosis, the EBUS would actually make a difference in the procedure that is going to be done to the patient, whether or not the patient is going to be operated or whether it is a patient with suspected lymphoma, then yes, I would want my pathologist to be there and to give me an answer. But if it is a routine run-of-the-mill kind of a patient, you know, where I know these are necrotic nodes on the CT scan and I'll be able to get a good yield, then probably people who have good experience with doing EBUS can do away with the Rose. So as you very correctly said, the literature is divided. It has to be an individualized approach. It has to vary from patient to patient. And where you think that it's a difficult patient, it's a difficult case, then yes, of course, you can go ahead and do a Rose in that patient. And coming to the second part of your question, sir, when the Rose is not giving you anything, I think a very important practical tip here is to talk to the pathologist. It's to always, you know, keep them in the part of the diagnostic process, to keep them a part of, to make them feel like a part of the team. Talk to them what you're actually suspecting, show them the CT scans, tell them about the history of the patient. And a lot of times, you know, that does help. They tend to see more stuff in their slides. And of course, you know, there are now techniques which can help you during the procedure to guide you towards what kind of node you should actually be sampling. For example, you know, if you have access to an elastography in your unit, maybe, you know, you can appropriately, you can hit the appropriate node. In a node, you can hit the appropriate area, take out sample from that area, guided by the elastography if you have access to it. I do not have access to it, but I've seen people using it and I think it works. But a very practical advice, as I said here, is talking to the pathologist, hitting different areas of a different node or probably changing your node. And at times it does work. The pathologists do tend to see things when you talk to them.
Fair point. Thank you, Arjun. Absolutely lovely. Vishwanath, quick comment from you and then I'll go to Yugandhar.
See, as you said, the literature is divided. The main obstacle in having a Rose is having a cytotechnician and a cytopathologist on site actually. So if you have a pulmonologist trained in rapid onset evaluation, that solves the problem. See, most of the times we are at least 1 or 2 people are there during the procedure. It definitely helps us even in large lymph nodes also, where we thought that the lymph node would definitely give a diagnosis. There were certain situations without rows where there was no diagnosis. So I think definitely if you have a pulmonologist trained in rows, it will definitely add to our yield.
So Vishwanath, have you managed to do that? Have you got people who can actually look at slides doing pros rather than rows in your unit?
We were just during the COVID times only we have started considering that. But
Yeah, right, right.
In the COVID
Sure.
time, we didn't start immediately.
Sure. So let me get Yugandhar into the discussion. So Yugandhar, do you think the number of passes, so we just talked about the negative rows when you sort of making passes. Suppose you don't have rows, you are like my unit where we actually have to send the slides away. Do you think the number of passes that you do through a node actually make a difference? And do you think you would actually apply negative suction, no negative suction, just pulling the stillet back? Is that so? What is your approach in getting a good yield on slides? Suppose you don't have rows in your unit.
Yes, sir. Regarding the number of passes, first question, 10 times for each station, that will be 10 passes. That will be good enough. If the material is good and we are using the single needle, some units are reusing the needle, that is also matters different. And number of gauge also, if it is a 19, yield will be good compared to 22. So after the third pass, third time of doing the same procedure for the same node, the yield will be not so good. So 3 times each pass, each node will be 10 times each passes will be good enough. And while spreading the slide, the material consistency, that is also matters, so that even though in the absence of rows also, we have that particular idea about whether the material is good, if it is thready like material, core biopsy like that, cheesy material like that. The number of passes matters if proper apposition, proper node, and proper technique. And regarding the second part of the question, that suction, frankly speaking, I never used that suction until it is a hard node and where there is a less vascularity and Doppler. If the vascularity is more, and if I use suction, the sample will be bloody and it is not going to give good result. In fact, it is hampers your results in terms of molecular this thing analysis. So suction, frankly, I am not using regularly, except that particular less common situations like hard node.
So thank you. That's great, Yugandhar. So anyone else on the panel have a thought on this? So 10 passes versus 20 passes. Do you think it makes any difference? That's one question. And the other question, so I think Yugandhar very briefly mentioned 19 versus 22, and I'll come to Yugveer about that. But do you think the number of passes, would you actually, so for certain nodes which are hard, which are difficult, would you rather go for sort of more passes rather than doing 10? Is there sort of horses for courses sort of thing, like he said about the other bit, the negative suction? Anyone?
So there are two different things. The one pass versus oscillations or jabs within the node. So I think there's some confusion in the number actually. So the pass is after you put the node till the time you take it out. That is one pass.
Sure.
So if you don't have rows, the recommendation is to do at least 2 to 3 passes per node. That is for the diagnosis. Sure. If you want molecular markers, you add two extra passes.
So Nagarjuna, we are talking about oscillations. You're absolutely correct. So talking about oscillations.
If you're talking about oscillations, then 10 versus 20, whatever data we have, I think both are equal.
So sorry, we lost you at the end. You said no difference, right? You said 10 versus 20.
10 versus 20, I think, was the paper which looked at the diagnostic yield, and it was similar in 10 versus 20.
Right. Okay. Grand. So let me come to Yugveer. Yugveer, if you come into the discussion and if you tell me whether, so we just heard Yugandhar talking about the size of the needle, 19 versus 22. So do you think the size of the needle matters at all? Would you have a preference depending on what sort of node and what sort of background diagnosis you're suspecting? And lastly, to add to that, do you think using a true cut needle actually makes any difference to the diagnostic yield?
So as far as we are concerned, we are using 21 gauge needle right now. 19 we have used once or twice. As far as literature is concerned, there is no difference between 21 and 22 gauge needle in terms of diagnostic yield or complication rate, whatever it may be. But when it comes to benign condition and lymphomas, basically 19 gauge will give us a bit of more material for histopathology as far as molecular markers or immunophenotyping. You can go ahead with that. That is what. And 25 gauge, we don't have much literature with 25 gauge as of now.
So Yugvir, I'll push you a little bit more. So suppose you had the option of having all these needles in your unit, right? So for a given patient with a background diagnosis of malignancy, what needle would you use and what sort of tissue would you want?
Malignancy, I think 21 gauge is enough.
Okay. Okay. Brand. So 21 gauge enough. Anyone else on the panel have any opinion on this? And then I'll come to Vishwesh. Get him in after that. Anyone else have anything to add, anything to change? Okay. So Vishwesh, we've talked about this in various segments. So Hari spoke about looking at the nature of the node. And I think there was a mention about putting the needle in at various angles in someone who's having a negative rose while on the table. So sort of putting all of that together, my question to you is, do you think trying to direct needles into particular portions of a large node, a significant sized node, actually makes a difference? And what strategy would you use in a more than a centimeter sized node when you're sampling it, and what characteristics of the node would you look at?
So if we are taking into consideration a malignant lymph node, then the better part should be, it should be from a cortex to cortex, because the malignancy spreads through the lymphatic route, and the first initial deposits will be in the sublymphatic region, which will be in the periphery of the node. So if you target your needle more towards the center, probably you may have a negative sample. So if you are suspecting a malignancy, the better is to go through and through from the cortex to cortex, which is a representative of the periphery of the lymph node. And again, in malignancy, it is better to avoid the necrotic regions because your yield of sample is always going to be low. And if you are having a vascular node, then it is better to avoid a suction because it is again going to contaminate your sample. And having said that, you have almost 10 oscillations per node. If you have a vascular node, you can limit those oscillations to maybe 3 or 4 because you are going to more traumatize the vessel and it may cause more bleeding and it may hamper your material. As far as a tubercular lymph node is concerned, since it is more of a microbiological diagnosis, though we can get a granulomatous inflammation on a cytopathology, even while targeting a necrotic lesions, many a times we have observed that we get a gene expert positive. So targeting a necrotic region in case of a tuberculous node wouldn't make much of a difference, but in malignancy, yes, it is to be better avoided. And one more aspect of malignancy is if you have a elastography, then you can characterize the segment of the node which really has a malignant deposit, which shows a very high stiff areas in comparison to the other areas. So you can do a elastography targeted aspiration of that part of the node, which may further may cause an increase in the yield of your sample.
Okay, fair enough. So that's a comprehensive answer. We'll leave it at that. And we'll come to Nagarjuna again. Nagarjuna, difficult question for you. So you've got someone who's had a negative EBUS. So this is a continuation of one of the previous questions we asked. So, and you cannot find any other area from which you can actually get a diagnosis. So it's your mediastinal nodes which are enlarged and nothing else. So what would be your next step? What's your thought process? How would you go about getting tissue? And how would you proceed in a case like this?
So I think if mediastinum remains the only place with disease and you didn't get a diagnosis on EBUS, then I think you should go and look into the clinical history also. So are we actually dealing with it? Are we actually expecting a diagnosis, or is there a nodes are actually reactive? So if we feel that the nodes are diseased and we didn't get a diagnosis on EBUS, then the second best investigation would be a surgical sampling. So then you're left with two options. You're doing a repeat EBUS or you do a surgical sampling. So if the first EBUS has been done properly and we didn't get a diagnosis, then I would give the patient the next option as a surgical modality.
So Nagarjuna, you've gone on mute actually. Yeah.
On the site, the node which we want to sample. So if it's a hilar node, then probably hilar, or if one ipsilateral nodes, then we would go for a VAT sampling. If it's a central node, paratracheal or subcarinal, then the conventional medicinoscopy would do. So I think this is how I would proceed.
So I guess absolutely agreed, Nagarjuna. Maybe from my side, 1/3 suggestion. I completely agree. Go back to the clinical history, see how the patient is, how important the diagnosis is. And suppose it's not desperate, you might also want to wait for 6 weeks and repeat a CT, isn't it? So that's the option you might have.
First thing was, if you're expecting the nodes to be reactive or some other diagnosis which can be achieved, then the wait and watch policy also can be done, whether to see the nodes are actually increasing, the patient clinical status is improving or not.
Right.
That is very crucial.
Grand. So thank you, Nagarjuna. So we'll speed up a little. We've got 5 or 6 questions to ask, so we'll speed up a little. Hari, question for you. So we keep hearing about drainage of these bronchogenic cysts, mediastinal abscesses, etc. So the first question is, have you got any personal experience? And we would like to hear that experience, a little bit about the case, if you can recap that and what you exactly did in that particular scenario. And then from the literature, do you think this would ever become an alternative to VATS drainage? And what are your thoughts about reaccumulation when you're doing it via EBUS as opposed to doing it surgically?
During our post-graduation days and during training, it is very exciting to see bronchogenic cysts on EBUS, and then we try to aspirate all these things. It looks very exciting those days, but once you start practice, really it's a very straightforward radiological diagnosis, and the straight treatment modality is surgical resection. So I don't think there is any point of doing a EBUS aspiration of bronchogenic cyst unless until you're writing some papers or on that, because the main problem with bronchogenic cyst is the chances of it turning out to be malignancy. That is the only problem with the bronchogenic cyst. And if you even do a EBUS guided aspiration of these needles, so you cannot prevent those things turning out from becoming malignant. So I don't think EBUS has any role in drainage of bronchogenic cyst, number one. Number two, if you're alone doing an endosonographic drainage of these things, you need a long follow-up around 3 to 4 years to see whether they reoccur or not. So that again, because in our Indian scenario, that long follow-up of patients is not really possible, whichever place you're sitting in. Then one more important thing is when you do a bronchogenic cyst aspiration, most of us do these cyst aspirations in our beginning of EBUS careers. So that's where our hands are not good in doing EBUS, and we end up in puncturing those cysts with 2-3 passes, and then they can become infected and also can lead to very potential complications. So the recommendation of drainage of a bronchogenic cyst is a single aspiration, which will not happen in the initial days of our training or in the initial days of our clinical practice. So once you mature, I think it is taxing, more taxing to the patient doing an EBUS aspiration of a mediastinal cyst than submitting them straight to the surgical resection.
So I love that answer, Hari. I'll come to you in a moment, Yugandhar, but I love that answer. And so I want the audience to hear. So these are the young stalwarts, the interventional bronchoscopists of India. And the reason I love your answer, Hari, is that there is prudence attached to your answer. So it's not a scope monkey who's going to drain, scope, needle, everything that they get, but use prudence, keep the patient's interests and safety in mind before they go and do a procedure. And that's not just true with the bronchogenic cyst. That is true with all patients that you scope, irrespective of what indications you're going to scope them for. So quick comment, Yugandhar, before I go to Vishwanath.
Yeah, I have experience with this presentation of subcarinal located bronchogenic cyst and compressing the atria and presenting as a recurrent atrial fibrillation. So after the thorough analysis and discussion with the CT surgeon and ruling out all causes of AF, then we went for the surgical excision. Patient is doing fine. I'm completely agreeing with the Hari, regarding this surgical excision is the answer because of these two reasons. Pressure effects may not be go because if it is a reinfection and there is a chance of recurrence of the same change.
Grand. Thank you, Yugandhar. So come to Vishwanath. Vishwanath, got a long question, but I'm hoping for a short answer. So, you know, these patients who have multiple comorbidities, and with sort of COVID being there, we have become even more used to this terminology of comorbidities. Everyone is talking about comorbidities. So chronic kidney disease, hemodialysis dependent patient, patient with heart failure, recurrent heart failure. I think Yugandhar just now mentioned atrial fibrillation, patient on long-term oral steroids. So in this group, are there any particular precautions you think of, anything that you would do different, starting from consenting to doing the procedure? How would you advise our audience as to go about doing things differently in this group of patients as compared to your bog standard EBUS-TBNA in a patient with little or no comorbidities?
So if you come to the chronic kidney disease and the congestive heart failure scenario, most of these patients are on antiplatelets or anticoagulants for chronic atrial fibrillation also. So if the patient is within 1 year of the coronary artery disease and stenting, then the risk of stent thrombosis is very high if you stop antiplatelets.
Sure. So Vishwanath, I'll come to Arjun with that question. So let's leave the antiplatelet part aside for a minute. Tell us about the rest, but that's a point well taken. So let's move forward from antiplatelets.
So if a patient is on hemodialysis, we would prefer to do an dialysis prior to the EBUS session, and the next day we would prefer doing the EBUS-TBNA procedure. And patient is on antiplatelets and anticoagulants that would be discussed. We would be doing like we will be stopping or not stopping depending upon the risk-benefit ratio and then proceeding ahead. But people are on high-dose steroids or chronic steroids, we would not be taking any specific precautions before doing an EBUS procedure.
And Vishwanath, when you speak to these patients, when you speak to relatives, do you actually quote a slightly higher risk, or would you actually talk to them about a slightly higher risk, or do you think it doesn't really matter?
So if a patient is having a normal LV function with like a coronary artery disease or so, we would not give a higher risk during the procedure, because EBUS is a very safe procedure. Even the risk of bleeding is very less. So unless they have like a severe LV dysfunction also, generally we would not give a high risk for this patient.
Okay. Okay. So Arjun, come to you. We've asked you the question. So antiplatelets, anticoagulation, combination of both. What's your mindset? What are you going to do?
So thankfully, there's nothing known as an emergency EBUS. You don't, do this procedure as an emergency. So you can always wait. And, the chances of the EBUS being a very low risk procedure for bleeding. The overall quoted percentage varies from 0.2 to 1%. If a patient is on aspirin, it varies again, the bleeding risk is same. On dual antiplatelets, from papers to papers, it varies between 0 to 7%. So the overall bleeding risk with EBUS is kind of very less. It's not really all that scary. However, I think it's the other way around. Stopping antiplatelet therapy, you need to be very careful when you're stopping it. Always take your neurology and your cardiology colleagues into the picture. Always talk to them, because as Dr. Jella was saying, a patient who has had an MI or a stroke within 1 year, a patient who has a CHADS2 AF risk of around 5 to 6, someone who has a prosthetic valve, stopping these drugs in these patients can actually be quite challenging. And you might actually, do more harm to the patient rather than, doing an EBUS procedure, where I think the risk of actually causing significant bleeding during EBUS is quite less. And whatever papers you read about this, they've taken the amount of significant bleeding during EBUS as 20 mils. I don't really know how you measure 20 ml bleeding during an EBUS procedure. But to my experience, sir, we have done EBUS in patients who are on dual antiplatelets. Now, I'm not telling everyone to do it, but we do know if we can stop it, we would want to stop these agents for at least a period of 7 days. And if you cannot really stop them, if the indication is so hard that you really cannot stop any of these agents, and you think that the patient might harm from stopping of these agents, then as much as possible, if your colleagues, your cardiology colleagues say that you can stop it for 3 to 4 days, even that amount of period is fine, because it's a relatively low risk procedure and patients don't really bleed that much during an EBUS.
Okay. And if you're doing it in a patient who is on aspirin clopidogrel, or you've stopped it for 2 or 3 days, what's your thinking about a large bore needle or a true cut versus a narrow gauge? Do you think it matters, makes a difference, or would you sort of go ahead and do it the normal way you would do it?
I have never really used a 19 gauge needle. I'm waiting to use it. So in my setup, the kind of needles that we have are standard EBUS needles.
Sure.
We've done it on patients who are on dual antiplatelets after stopping it for 2 to 3 days. Touch wood, thankfully, never seen
Sure.
any significant bleeding with them.
Sure.
No experience with 19 gauge needles.
So I'll quickly come to Yugandhar. So last 2-3 minutes of this panel discussion, which I have absolutely loved. So question for you, question probably the entire audience wants to hear the answer to. So Arjun just said that there is no emergency EBUS. So COVID times, risk for the patient, risk for healthcare personnel. What's your attitude to doing an EBUS-TBNA in this scenario? Would you actually get one test done, RT-PCR? Would you get 2 RT-PCRs done? None at all? So tell me your mindset and how you got about adapting to the new normal, Yugandhar. You're on mute, Yugandhar.
To answer honestly, I have had 2 situations in doing a EBUS. One patient where our RT-PCR was not freely available time. So I went for the straight away CT scan, which is fair enough, normal, relatively no ground glass opacities, no signs of viral infection. Pure lymph nodes, only almost 120 kgs of the body weight. And I don't want to take chance, so I went for the EUS colleagues to come into the picture. Sarcoidosis was a diagnosis, I'm following that case. After that, so I'm going with this RT-PCR negative, where it is freely available. Once it is RT-PCR negative, wearing a full face respirator and PPE kit, I'm going for that. Practically, we are reduced our number of EBUS in our center, that is Malakpet branch in Hyderabad. So particularly this situation, because of this is a relatively not emergency procedure.
Okay. So quickly, Hari, what sort of numbers are you doing? I hear you do lots of numbers. So what numbers are you doing of EBUS at the currently?
Last 2 months, we are doing around 10 to 12 a month.
10 to 12 a month. And what RT-PCR, just sort of basing them on RT-PCR, one RT-PCR, or sort of what's your...
If the RT-PCR is from outside and more than 4 days, we do a rapid antigen before the procedure.
Okay.
If the patient is directly coming to us, we do PCR 1 day before.
Okay. Okay. Grand. So I'll come to Yugveer. Yugveer, pediatric patients. So this is where I'm completely lost actually. I don't do these, but sort of pediatric patients or patients who've got who maybe not got trismus, but have got a very tough temporomandibular joint, difficult to open the mouth completely. So these 2 scenarios, have you got any experience, or from the literature, is there anything you want to tell the audience about patients who are sort of above the age of 10 maybe, or above the age of 7, and people with a temporomandibular jaw dysfunction? I can see Vishwanath's hand. I'll come to you, Vishwanath, after you, Guvi.
As of now, I don't have experience with pediatric EBUS right now. And pediatric cases, the main thing is management of the airway during procedure, because whatever EBUS we are doing, it is 6.9 millimeter, and managing airway. As far as the literature is concerned, they are saying EUS-FNA is preferred over EBUS if subcarinal node is there. Rest of all, I don't have much experience or the literature.
And the jaw problem?
Jaw problem, the best one is even the nasal approach of EBUS. And the diagnostic, as far as literature is concerned, the diagnostic sensitivity of nasal versus oral, there is not much of difference. If jaw they can't open, it's better you can do some nasal route.
I have actually tried the nasal route and have found it quite difficult. So I'd be interested in what Vishwanath has to say. Vishwanath, you raised your hand. Anything to add to what Yugveer said?
So I have some experience with doing EBUS in pediatric patients. The youngest patient we have done EBUS was in, I think, 8 years baby. So we used it. We used an esophageal route. We did an EUS-FNA actually, because the EBUS scope would not be possible to pass through the trachea in such engage actually. So we had done EUS-FNA from the right paratracheal, subcarinal, and the paraesophageal lymph node stations. In fact, I was part of the one retrospective analysis which was published from India, wherein multiple centers have participated. where every center has shared their experience and said that the EUS-FNA in pediatric patients is a very feasible one and a safe one, and good diagnostic yield is there from EUS-FNA.
Okay. Okay. And any comments about someone with a tough jaw, temporomandibular joint and sort of nasal root? Anyone experienced with any nasal root? Yeah.
We had one patient who had CA buccal mucosa, where there was the patient was post-op and then post-radiotherapy. So there was a limited mouth opening. In this patient, it was an adult patient actually. So we had used EBUS scope through the nose and then went into the esophagus. It was a paraesophageal lymph node. So we went into the esophagus and then aspirated the paraesophageal lymph node. And then in that particular case, since the nasal cavity was roomy, actually we were able to do it well. But definitely there would be patients where the nasal cavity is narrow and there would be some challenges.
I can see Nagarjuna smiling. Nagarjuna, any comment that you wanted to add? No?
I think whatever people have said is perfect. So a pediatric age group, definitely USB would be the modality.
Okay. So the last word goes to Vishwesh. I mean, rightly so. So Vishwesh, you want more tissue. So maybe you've got a patient with lymphoma, and let me know your thoughts about something that's been mentioned already today, the intranodal forceps biopsy. Have you used it? What scenarios, what clinical scenarios would you use it in? And how easy or difficult have you found it as a procedure?
Sir, actually it is basically, as per the literature, it is tried mainly in 2 cases where the yield of conventional EBUS is low, that is in sarcoidosis and lymphoma. So what they actually do is, it initially started off even in the conventional TBNA before the EBUS came. So they used to make a small hole after repeated passes and then insert a micro catheter which is of diameter of 1 millimeter or a 1.2 millimeter. 1.2 millimeter is the Boston one and the 1 millimeter is the Olympus pediatric forceps. So under the vision, and they used to take the biopsy. Later, after the advent of the EBUS, now it becomes a real-time visualization of the forceps into the node. But there are a few challenges while really doing it, because when you try to push the forceps, it may not go through the same tract which you have created with the help of your EBUS-TBNA needle. In fact, you need to push the forceps from a proximal end because it will slide over the mucosa before it enters into the groove. So it will come with a repeated experience, and to be very frank with you, I have not tried per se, because we have the access to 19 gauge needle, which gives a significant amount of material. But this one modality can still be tried when you have a repeated EBUS samples coming negative and you have exhausted all your other resources. Still you want to make a diagnosis, or you are in search of a larger amount of tissue, especially for a malignancy where you want to do the molecular markers like a PDL1 and other immunophenotypings. So only in that cases it really makes a sense. If not, in most of the other cases, with the advent of the Procore needle or with the advent of the 19 gauge, you can get a significant amount of the tissue which will really solve your purpose. So it is more of a exciting and an exciting thing, but with the newer advancements, I don't think it is of that utility in a routine EBUS practice.
Thanks, Vishwesh. We leave it at that because we've overshot time by 7 minutes. I'm sorry about that. Absolutely loved my time with all of you. So Arjun, Hari, Vishwesh, Vishwanath, Yugandhar, Yugveer, and Nagarjuna. Absolute pleasure talking to all of you. I hope the audience finds this panel discussion as interesting as I found it. And congratulations again to Dr. Vishweshwaran for having put all of this together. And I hand over again to you for the continuation of the program. Vishwesh.
Thank you. Thank you everyone for attending this web conference on topic linear EBUS. So I hope that everybody would have learned many new things in these last 2 days on various domains of the EBUS. I would like to take this opportunity to thank the Yashoda group of hospitals for supporting this educational initiative. My special thanks to Dr. Pawan sir for taking a personal interest in this program, and thanks to Dr. G.S. Rao sir, our digital team, the branding team, my friends and colleagues who have supported in organizing this meet. I sincerely hope that we will be joining for a third International Interventional Pulmonology meet, maybe with a different theme. So till then, Thanks, everyone, and have a great day, and hope to meet you all soon, probably in a non-COVID setting. Thank you.